Let's continue yesterday's chapter 13, stroke. So I wrote out a few things so we can continue. The page that this begins on is it's 80. So look at page 80, top left, we'll begin. This is right after diagnostics. So it's like patient-centered care. Now if you look from page 80 all the way up to end of page 81, is all patient-centered care. Things that we should do for a patient with stroke. And there's a lot of information, but I've tried to really highlight and key point the very specific that are usually the answers or that you should know, and you know also what you're gonna literally do as a nurse. Because some of it is perform neuro checks and check vital signs, assess this, it's very generic information. If you look through it, feel free to. Okay? But as we read, you'll see that it talks about the Joint Commission explains and having VTE prophylaxis and thrombolytic therapy, which basically means, again, we want to prevent clots, right? We want to make sure that they don't get an embolus. So it's all this information, but here are the key highlight notes of the actions to take so that we prevent further complication after the stroke. So understanding, that when this person has had a stroke, usually on one side of their head, they've had major damage or mild damage, and this leads to then the opposite side of the body having weakness, paralysis, vision problems, They have a neurodeficit, problem on the other alternate side. And that's a key thing for you to know, by the way, that if the left side of the brain is affected, the right side of the body is what's going to experience it, and vice versa, okay? So I've seen that question beyond that. They say they experience a left focal infarct, and then what side of the body are they going to experience the symptoms? It's on the right side. I've seen that question come up. So, some other things to do. The big surrounding ones are, one, they can have trouble communicating. They can now develop what's called expressive or receptive aphasia. Aphasia is the inability to communicate or more so translate or actually express. Now, if it's expressive aphasia, this means they have a problem saying, communicating. Or they can have receptive aphasia, meaning when you talk to them, they hear you, but they don't process the information correctly that they're hearing. So they mix it up. And likewise, when they have expressive, they know what they want to tell you. It's not that their mind is gone, but when they try to speak, it's not what they want to say. But they know what they want. They know what they're trying to say. You could see the frustration in them because they're trying to tell you something. When I say, I'm hey, grab the door, and I'll be look, under desk, And then it's look, under desk, and I'm trying to tell you, go open the door, but it just doesn't come out. Something else does. Does that make sense? That's expressive aphasia. Or they can't speak. So they can either speak, then it'll be speak slurred, very incoherent and illogical, or no speech at all. It goes down on the scale of how much speech ability they have. So it can be that they slur a little bit, it's hard to understand them. They can be a little bit illogical, or they could not speak at all anymore. So it depends how severe the damage is, but that'll be expressive aphasia. Receptive is, like I said, they hear you, but they don't process it as coherently. And they can have one or the other, or both. Okay? So the way that you're going to assess the aphasia is with simple commands. Please raise your right arm, Raise your left arm, grab this. Can you point to the cactus? Can you point to the eagle? Can you point to this? You're going to give them forms so that they follow simple commands. Now, you avoid yes/no questions because with patients that develop this, the problem is they have expressive aphasia. They can be trying to tell you no, but maybe because of their aphasia, all they can say is yes. And you've seen that. If you haven't seen that, it's a bit hilarious, but it shouldn't be. Because it took me a while. I look back into the person that it happened to me, because I was do you want this? And then they're yes. And then it's do you want this? And it's yes. And then I eventually caught it, because I would ask them something weird, and they would be yes. And it's that's what, that doesn't make sense. And then I caught on, and they always say yes. So it's an expressive aphasia. Okay? Right? So it's Yeah. Right? You got to pee? Yes. You have to poop? Yes. And they probably don't have to. And then I was like turning them, and I'm like, what? It's like, and it's weird.
How long did it take you?
Not long. It was when I was doing clinicals as an LVN until I caught on that the man couldn't say anything except yes. So that's why you want to avoid the yes/no question. You want to give a simple command and see if they are able to follow it, and then they understand you. Make sense?
Can you write it out?
Sure. Some of them prefer to read and write. So that's the answer. When people have expressive receptive aphasia, what are we gonna do? Give them pen and paper, picture boards, or communication boards are gonna be the answer. Because this allows them for ease of communication. Again, they can point that they wanna have a bowel movement, that they wanna void, that they wanna eat, that they wanna drink, that they wanna turn, right? They can just point to the commands that are on the picture board, to the frequent ones. Make sense? You put everything on their bedside table, make sure it's within reach. It's pretty obvious just to prevent falls. Okay? So, speak slowly, clearly, and one of them is like when people try to like yell or raise their voice, like it's not gonna make a difference. You need to speak slowly and clearly is the difference. Okay? And with all that is for speech and communication. The next thing is their swallowing ability to be altered. So, if they recently had the stroke and they have not ate since this happened, right? And they got transferred to you now from the acute care, right? Or you're monitoring them and they haven't ate since the stroke happened, then the first thing that we're gonna do is, and a lot of people get this wrong, the first thing is they are nothing by mouth until the swallow evaluation is completed. This is because we don't know their ability and we wanna avoid having them choke. So monitor for dysphagia. Now when they do begin eating, we monitor for it. And what are gonna be the signs? We talked about it yesterday. I tell you like the most obvious one that usually happens.
Coughing.
They'll cough when they drink a thin liquid. Okay, so this shows that they're impaired ability to swallow. You can also see drooling, gagging, coughing, choking, or pocketing food. Or they take too long. They're taking like longer than 10 seconds to swallow the food that they're chewing. So they're unable to swallow. Okay? Now when they do get cleared by speech pathology, and you'll see that on there, there's different levels of diet, like from 4 to 1, of how grave it needs to be, whether it's thick, mixed and moist. So when they do get approved for a diet, okay, we begin to feed them, but they still have aspiration precautions. Here are some of the common ones that we're gonna follow. 1, you wanna obviously have the head of bed up. They should be in an upright position when they're eating. They should not be laying down or to the side or anything like that. Upright, high Fowler. Second, a lot of patients that are bedbound or have had strokes or just bedbound in general, but it's now speaking specifically to stroke, they tend to do this when they, imagine they eat when they're just like, even sitting, they do this. You see them like lean their head back. It's this because of the positioning of the pillow. They have it too far down. It's the way that they are because they're in bed all day. Like they do this. And so when you're doing this, your airway is much more open than as opposed to if you tilt your head down, your epiglottis is forced to be closed over your trach. Hence, when you're doing CPR, right, and people are like this or whatever, what's the first thing you do? You position the head, you tilt it slightly back. This will open the airway. So you want to now close it. So you'll tilt them this. Another way that they phrase that in the test of the answer is have them meet chin to chest. Because they're trying to put their chin, you can instruct them, tell them to put their chin to their chest or try. This will naturally make them do this. So any way that they phrase it, they'll say either flex the neck forward, chin to chest, lower your head. Okay, you're trying to make this motion here. This will close the airway and it makes it so that when they swallow, they're not aspirating. The next thing is they'll sip or drink from the cup, and you don't want them to use straws. It'll increase the risk for aspiration. Next thing is they place the food in the back of the mouth, especially those that have difficulty or one-sided weakness. Put it on the unaffected side towards the back of their mouth. And generally, once the diet is ordered, the RN will do the initial feeding to assess for how they tolerate the diet. Make sense? So if you read through the book, again, you have a lot of information about positioning and whatnot. This is the verbiage and the key that you need to understand, and again, just be able to apply it to the question. So it might not be word for word right here. It's not gonna say right like head and neck, flex forward. Like I'm telling you, some version of that, you understand they're trying to create that motion so that they can, I'm trying to give you the purpose, so whatever way that you see the question, you're able to apply this action to your question, to your problem. Next is mobility. Assistive devices are always to be used. They can also, if you see that they have hemianopsia or homonymous hemianopsia. Homonymous starts implying that they have the same visual field, so maybe both on the left side. They've lost the left field of vision on both eyes. So this eliminates partial field of vision. So anytime you see hemianopsia or homonymous hemianopsia, you will then teach them to scan the room, okay? When they're gonna get up and ambulate, or when you put them their tray, you have to teach them to scan, all right? Do this motion with their head, so that way they can see everything that's in front of them, because their visual field is impaired. They might miss something. Other devices that are useful for them are things like plate guards, clothes and shoe hooks, loop fasteners, are common ones that you see on there. So you see the devices that to be used for them, it's I guess. This is all found on page 80 and 81 throughout all that information. You look for patient-centered care, it goes all the way until the end. Okay? Have them ambulate frequently as possible, perform leg exercises and turn them at least every 2 hours. Especially when they have decreased mobility, this will help prevent any pressure injuries. Things to prevent emboli, SCBs, anti-embolism stockings. Good? All right. Now, out of the medications, there's one, the others you've gone over at some point. It'll take stool softeners to not strain. Aspirin and anticoagulants are going to do what? Prevent forming of new clots, right, and further strokes. But there's one that we haven't really gone over and that is very specific to stroke, and that is the thrombolytic medication, TPA. Now the class is thrombolytics. They are also known as TPA, and the name for it is usually alteplase, or they'll end in plate. Okay. Now this. The key thing is that anticoagulants, aspirin, warfarin, all of those prevent clots. But this one, lytic, breaks down, right? Lytic means breaking down. This one breaks down or dissolves the clot. So let's look at there. Goal is to administer within 45 minutes of arrival. This is the bottom of page 81. You want to start giving medication within 45 minutes of arrival to the emergency department. And you can give within 3 to less than 4.5 hours of initial manifestation. Meaning when they started experiencing these symptoms or the stroke. Contraindicated with people who are bleeding. Now, another thing is if they have a recent surgery, I think it's within the last month or two. Surgery. These are contraindications because you're gonna break down the healing and the clotting that it's already doing. You're gonna make them bleed out. So you'll monitor while administering this for bleeding. You put them at risk for it. Ecchymosis. TKA. Right? Tachycardia. Hypotension. Altered level of consciousness.
What happens if you give it to them after that time? Like, will something bad happen?
I think it's not as effective anymore, is my understanding. I'm not sure about why they're timed, but I think either the effect or there's too much of a risk without the benefit.
Okay, thank you.
Okay? Now look over to complications. We have two: aspiration pneumonia and unilateral neglect. But these two are already covered with the actions we talked about. Aspiration pneumonia is them aspirating. So if we read over the client education nursing actions, it's the same thing. Contact speech negative pathology, sit them upright, chin down, provide the food consistency that they need. Watch closely for choking, drooling, coughing, right? Same thing. The unilateral neglect is that they neglect the weak side. They're not conscious of it. So again, teach them to scan, and if the arm is usually hanging and they don't even pay attention to it, what will you do? Get them a sling, so that it holds it up and they acknowledge it more. They sling their arm. They don't really focus on this no more, so I'm guessing it's not important, but depending on the side that they've had, the stroke, it affects like, almost like their personality, or at least just like their way of thinking. So for example, if they have a right hemisphere stroke, they tend to like lose, I think, like creativity, and they're, or there's one of the key factors of the right hemisphere is that they're very impulsive. So they no longer have like the safeguard, they just do. Like they don't really think things through. Like they overestimate their ability almost. So like for example, they might struggle to go upstairs or downstairs, but then get an opportunity, they just try it. They're very impulsive. They don't think about it. But when they have a left-sided hemisphere stroke, they're more cautious and guarded, and I think that's the one where creativity is down. Depending on which side, one of them is the reading and writing ability, math. So it can depend on where the stroke is that it affects certain things. Okay? Alrighty. Let's see if we got a break at 11:30. Let's try to get through the eye disorders. Now, I'll be honest with you. For the eye disorders, there's just a few things that I need you to focus on. And that is one, being able to like recognize or identify them. This means you must know the expected findings. You have to be able to classify them. So if the client reports a central loss of vision, or they feel like a curtain is coming over, or they feel cloudiness, you have to, and then how the eye looks, you have to be able to assume what it potentially is based on just the experience. Or like my eye suddenly started hurting very painfully. So you have to know what is potentially happening with, which is again, just knowing the expected findings. Additionally, risk factors. okay, for each one. And then we're gonna do a couple that have like surgery potential to fix it. And with that one, it's just like how to position them, or I know that I don't even know this is cover the surgery. Yeah, they do. Okay. So let's begin. First one, macular degeneration. Okay, macular degeneration, often called age-related macular degeneration, is the central loss of vision. Macular degeneration. And this is a central loss of vision. So imagine the center of where you're looking at, you just see a black hole. Okay, no cure. And it is a common loss of vision in older adults. Okay. Risk factors: smoking, hypertension, females, being short body stature, meaning you're short. Short lives matter. Diet, lacking carotene and vitamin E. Obviously, age more than 60 years. And being Caucasian.
What's carotene?
Carotene?
What is that?
It's like a mineral found in a lot of like vegetables. Generally, carrots have a good amount of it.
Oh, so like when they say, oh, carrots are good for your eyes, that's what it is.
So
But I'm still blind.
it's almost like a myth. So they say like it's kind of like a myth. So they say like if you eat carrots, you're gonna improve your vision. But it's more like if you eat carrots, it helps decrease the risk of you like losing your vision. Yeah, it's not gonna make you like develop better vision. I think that's a misconception. Like you need keratin and vitamin E, but you're not gonna fix your vision from eating a lot of it, or like it's not gonna be like superb because your kid eats keratin. It just helps prevent like loss, if that makes sense.
Okay.
Is my understanding. All right. Expected findings. So one. So here's how you know. Now this is the key factor right here, by the way. Central loss of vision. Now, other expected findings though is lack of depth perception, so how far or close objects are, how deep. Objects appear distorted. We talked about loss of central vision, and essentially as well, just blindness. On macular degeneration, yeah. So that's how we try to cover as much as we can, because some of these obviously like from immune as well, immunology, HIV and AIDS will come up, and we haven't covered it yet, so I try to push the proctor as far back as possible.
It was seeing halos with artificial light, center eyeball.
If I'm not mistaken, it might be glaucoma. Alright, so Diagnostics, they'll use, an ophthalmoscopy, so patient-centered care. So what will we do? They can receive laser therapy to seal some of these vessels. Okay? And, ask clients to increase, to consume, right, carotene, vitamin E, so I just put like this, big E. Okay, as loss of vision progresses, clients might be challenged with their inability to eat, drive, write, read, as well as other activities. Refer them to community organizations to help with their blindness. Non-curable. It might help with some laser therapy to seal some of the vessels, but essentially you'll eventually go blind. There's also drops, like that help slow it down. That's wild when you think about it, being blind. Take it for granted, but yeah, I probably, if I had to lose one of the senses, it probably would be the vision.
Nah.
Very good. Sense of touch. Sense of touch or smell.
Let's play. Would you rather be deaf?
Deaf or blind?
Deaf.
Subtitles without.
Hey,
I can't play video games without that.
deaf?
I like their sensitivity, so I guess my sister touches that.
Being deaf is wild though. Could you imagine like you're just on the toilet